Today, we're diving deep into MALT lymphoma, specifically looking through the lens of the World Health Organization's 5th edition classifications. We're going to uncover its fascinating journey, starting from chronic, localized inflammation all the way to a state of full genetic autonomy. If you really want to understand the modern pathological and clinical approach to this incredibly unique disease, well, you're absolutely in the right place. Let's get into it. Here is our roadmap for today. We'll move sequentially through definition and etiology, pathogenesis and genetics, histology, the highly specific gastric MALT scoring systems, treatment workflows, and finally, transformation and prognosis. Starting with Section 1, definition and etiology. What exactly is MALT lymphoma? Let's zoom in on what's really happening biologically. MALT lymphoma is essentially an indolent, mature B-cell proliferation born out of a chronic, localized battlefield. What makes it so fascinating is that it pops up in tissues that typically have little to no organized lymphoid tissue to begin with. Think about it. The body is constantly fighting a local battle, whether it's fending off an infection or mistakenly attacking its own tissues. In doing so, it recruits B cells and T cells to the site, which eventually expand, mutate, and turn clonal. And you have to know the site to know the suspect. The geographic and biological specificity of these etiologic drivers is just brilliant. Specific organs are tied directly to specific inflammatory culprits. In the stomach, which is by far the most frequent site, the primary driver is Helicobacter pylori. In the salivary glands, it's typically the autoimmune condition Sjogren's syndrome. The thyroid is heavily linked to Hashimoto's thyroiditis. Meanwhile, ocular adnexocases are often tied to Chlamydia psittaci, and the small intestine to Campylobacter jejuni. Moving on to Section 2, pathogenesis and genetics, or how this disease evolves to autonomy. Understanding the lymphoma's stepwise evolution reveals what we call its path to autonomy. In Phase 1, the antigen-dependent phase, the lymphoma clone is totally reliant on persistent T-cell help, cytokines, and microenvironmental stimulation. At this stage, if you remove the antigen, say by eradicating that H. pylori we just talked about, the lymphoma often actually regresses. But if the disease is allowed to progress into Phase 2, the cells acquire genetic abnormalities that lock their survival pathways into an always-on state. Suddenly, the lymphoma becomes antigen-independent. A crucial turning point here is the BIRC3/MALT1 translocation, which results from a T11,18 chromosomal rearrangement. This is literally one of the most defining mutations in MALT lymphoma. It fuses BIRC3 with MALT1, and that constitutively activates NF-γB signaling. This is the exact mechanism allowing that B cell to survive without any outside antigen stimulation. Clinically, this is massive. If your patient has this translocation in gastric MALT, throwing antibiotics at them alone will likely fail because the lymphoma no longer cares whether the H. pylori is gone or not. All right, Section 3, histology and phenotype. Let's look at the diagnostic features. Under the microscope, you're hunting for a variable mixture of marginal zone, monocytoid, and centrocyte-like B cells. You will often see them growing around reactive follicles, a process known as follicular colonization. But the absolute hallmark, the smoking gun you're looking for, are lymphoepithelial lesions. This is where clusters of neoplastic B cells invade and actively destroy normal glandular epithelium. You might also spot marked plasmacytic differentiation, complete with Dutcher bodies and light chain restriction. Now, knowing what MALT is not is just as important as knowing what it is. When comparing it to key mimickers, if the cells are CD10 and BCL6 positive, you need to suspect follicular lymphoma. If they're CD5 and cyclin D1 positive, you're likely looking at mantle cell lymphoma. If it's CD5 and CD23 positive, think CLL or SLL. So to efficiently isolate MALT lymphoma from the pack, we rely heavily on its negative immunophenotype, specifically the fact that it is CD5 negative and CD10 negative. Which brings us to Section 4, gastric MALT and a scoring, distinguishing between diagnosis and response. So here's a major question. How do we accurately score these gastric biopsies before and after treatment to avoid critical diagnostic pitfalls? The key challenge for specialized medical professionals is knowing exactly which criteria to apply depending on where the patient is in their treatment timeline. Using the wrong scoring system at the wrong time is a classic and dangerous diagnostic trap.
The golden clinical pearl here is this: use the Wotherspoon score only for the initial diagnoses and strictly switch over to the Jalea categories to assess remission post-treatment. The Wotherspoon system was never designed to assess how well a patient is responding to antibiotics. It's simply a measure of diagnostic confidence to help you separate reactive gastritis from an actual lymphoma in the first place. Applying the Witherspoon criteria to that initial biopsy, a score of 5 is your confirmation. You'll see a dense, monotonous infiltrate with those prominent destructive lymphoepithelial lesions we talked about earlier. Conversely, scores of 0 to 2 point toward normal mucosa or just reactive gastritis. But beware of scores 3 and 4. These are indeterminate gray areas. They absolutely demand additional molecular studies like IgH clonality testing alongside a very close look at the patient's overall clinical picture. Section 5, Treatment Workflows. Let's talk about sequencing therapy. Let's walk through the initial algorithm for gastric MALT step by step. First, thoroughly test for H. pylori. Interestingly, even if that initial test is negative, current guidelines often support giving eradication therapy anyway because false negatives are so common. So you administer a PPI and antibiotics. Then, and this is absolutely vital, you must pause the acid suppressive therapy before confirming eradication to avoid a false negative on the follow-up breath or stool test. Finally, you wait. Histologic regression can safely take several months, sometimes well over a year. Do not rush to escalate therapy if the patient is otherwise stable. And when we evaluate that follow-up biopsy, that's when we use the JELA system. If the JELA assessment shows complete remission, we simply observe. Fascinatingly, even if there's probable minimal residual disease or responding residual disease, observation is still very often the right call, provided the patient is stable and improving clinically. However, if there is no change, meaning you still see a dense, persistent infiltrate with no meaningful stromal regression, then we have to pivot. For localized disease that fails antibiotics, involved site radiotherapy is highly effective. But what happens when the disease is more advanced? For disease that is disseminated, multifocal, or presents with a high tumor burden and cytopenias, local therapies just won't cut it. Systemic therapy becomes the preferred pathway. Rituximab, which is often combined with chemotherapy agents like bendamustine, is a major systemic option here. Finally, Section 6, Transformation and Prognosis. We always have to be on the lookout for histologic transformation to diffuse large B-cell lymphoma, or DLBCL. If an otherwise stable MALT patient suddenly presents with a rapidly enlarging mass, rising LDH, or new classic B symptoms like drenching night sweats and sudden weight loss, your alarm bell should be ringing loudly. A repeat biopsy is absolutely mandatory at this stage. You cannot just guess based on symptoms. You have to prove the transformation pathologically before escalating them to aggressive DLBCL treatment regimens. But remember, pathology is highly nuanced. Seeing a few scattered large cells or immunoblasts under the scope isn't enough to call it a transformation. True transformation requires confluent sheets, or massive destructive aggregates of large B cells showing high proliferation. The baseline architecture of the indolent small cell pattern must essentially be obliterated by these aggressive large cells. This expert note from the WHO 5th edition brilliantly summarizes our journey today. It perfectly captures the biological thriller of a B cell learning to survive entirely on its own. We've seen how it starts as an innocent immune response to a local irritant, slowly builds a dependent clonal population, and then, through a critical genetic mutation, escapes the need for that initial trigger altogether. I want to leave you with this provocative thought regarding the complexities of MALT lymphoma. We know that IgH clonality can remain detectable by PCR long after the biopsy shows complete histologic remission, without necessarily indicating clinical failure. So it begs the question, in the era of ultra-sensitive molecular tracking, where do we draw the line between a harmless, persistent molecular clone and active, dangerous disease? It's definitely something to ponder until our next deep dive.